This conference will now be recorded.
Very good evening to all of you. My very sincere thanks and regards to Professor Murthy, who is a close friend and associate, and all the ENT fraternity of AOI Andhra Pradesh for giving me an opportunity and honor to be with you today evening and share some of my ideas on today, the World Hearing Day, that is 3rd March. Uh, my association with deafness is multifactorial. I am associated with the issue of deafness for more than 20 years now as a member of National
Hello,
Committee
sir.
of Indian. Sure, sir.
Sir, one minute, sir. I will read your CV, sir.
Okay, sir. Sir, I think you can do it in the end. It's not important. I think more
Okay,
important
okay,
is
okay, okay. Thank you,
okay,
sir.
sir. Okay, sure. So my association with deafness is that I am a member of National Committee of Indian Medical Association for Safe Sound for last 2 years. I'm a member of Sound Hearing. I'm a WHO representative of Southeast Asia, member advisory committee of National Program Prevention Control of Deafness, and I'm also member of National Initiative of Safe Sound, which Dr. Panikar is leading in the country. So I am very honored and privileged to be with a learned fraternity of Andhra Pradesh ENT colleagues, and I have been asked by Professor Murthy to just have some interaction amongst us on topic of neonatal hearing screening. Now, I'll just be playing a small video clip. Is the video clip visible, sir? Professor Murthy, is the clip playing there?
Yeah.
Yeah. So this is a small clip from a movie Koshish, where both parents are deaf and dumb and they are blessed with a child.
इसके कान भी तुम्हारे जैसे हंसने लगा आपको तुझे अभी से जू 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 जू
See, this movie is about 35-year-old movie. Then also, the concept of neonatal screening was there, but we were not very scientifically sound to address it. So we were just going by observation and comments by elderly who were evaluating the child and commenting about the hearing status of the child. So if we go back, if we now consider it as per today, there are various types of handicap, and all the handicaps, they are visible handicap. If you see a blind person, you lend a hand to the person to cross the road. If you see a limb disability, you try to help the person to cross the road. If you see a mentally retarded child, you try to help the child as a special child. But unfortunately, deafness is invisible. You only come to know about the deafness or about a deaf person when you talk or interact with the person. So this person rarely gets sympathy or empathy which he or she deserves. So it is an unfortunate part of this disability. It's a very ignored disability. If we go by words of Helen Keller, it is blindness separates people from things, deafness separates people from people. So it is when we talk about neonatal hearing screening, the key issue is that 93% of deaf children, they are born into hearing families. So the parents are normal and average age of identification is about 2.5 years. We as ENT surgeon know that we today follow the formula of 136. The deafness, congenital deafness, is to be identified within 6 months of birth, but usually it is diagnosed by the age of 2.5 years. All of us who are doing cochlear implant, we believe that 2.5 or 3 years is an age by which already the role of neural plasticity gets into consideration. Now, second point to concern is deafness as a congenital anomaly is not a single handicap. In about 40%, they have additional disabilities. If we go by incidence, hearing loss, the contributes or congenital defects of ear, they contribute the maximum among all the other congenital defects of the body. Why it is early to identify hearing loss? First, it is the most frequent birth defect. Second, undetected hearing loss has serious negative consequences. Third, early identification and intervention helps improve speech, language, social and academic development. And the foremost, that an early intervention enables parents to make timely and informed decisions. So early identification is the key. If we go back to the concept of neonatal screening, it was way back in March 1993 when National Institute of Health, it suggested that all infants should be screened for hearing impairment prior to discharge from the hospital and should be not later than 6 months of age. This was a recommendation almost 28 years back, and many of the countries started following these guidelines. Unfortunately, in Southeast Asia, particularly India, we have not yet started following these guidelines strictly. We all as ENT surgeon know that critical period for language acquisition is between 0 to 3 years. This is the most critical period when the child acquires a language, and language is totally dependent on hearing. The child hears, develops a vocabulary, and then develops language or speech. But it has been seen that in cases of mild to moderate hearing loss, the delay is between 18 to 28 months in high risk or no risk category of children. And in severe to profound, it is almost 1.5 to 2 years. And 50% of children with moderate to profound hearing loss exhibit no risk factor for hearing loss. What I mean to say is, there have been neonatal screening programs in high risk patients, children who are in ICU, PICU, NICU, but 50% of the children who are born in a normal setup, they have hearing loss. If we go by WHO statistics, 32 million children live birth have disabling hearing loss. 60% of childhood hearing loss is preventable. 31% have infections which are curable. 17% have birth-related causes. Then 4% are related to ototoxic medication, and only 8% are which are not known for. The consequences, if we are not detecting hearing loss in right time, they are delayed language development, academic underperformance, social isolation, higher risk of injuries, increased poverty, and poor quality of life and cognitive domains. Worldwide, 130 million babies are born every year, and almost 5 lakh they are hearing impaired. If we talk about our country, 1 in every 5 children born with hearing loss are born in India. So we are contributing almost 20% of congenital deaf children in the world. And if we go by other statistics, the prevalence of sensory hearing loss is the most common birth condition. It is 0.8 to 3 per thousand in the world, which is 1 to 8 per thousand in India. If we go by the prevalence as per the WHO report, which was about 10 years back, they said there is a lack of epidemiological data in most countries. India, as compared to other countries, it showed that we had a prevalence of 1 to 6 per thousand, and the high risk infants, and 1.6 per thousand live birth if we talk about a combined population of children. If we talk about universal neonatal hearing screening program going on in the world, the achievement is 95%, 80%, 40% in various countries, but in Southeast Asia, we do not have the true statistics about to talk about. If we talk about Southeast Asia, as per the Statistics of Sound Hearing 2030, we have three areas of concern with deafness. One is the national policy. Second is provision of hearing aids by expert and cochlear implant program. India is fortunate to have a national policy by the name of National Program for Prevention Control of Deafness. We have facility of hearing aid in the smallest city or district of the country. Many centers are successfully running cochlear implant program in the country. But if we talk about various countries in the world, a small country like Philippines, they have 90% coverage of newborn hearing screening, which besides India, 14 low income and 53 low middle income countries do not have an affordable solution for early screening of hearing impairment. If we go by NSSO survey 2002, it is a large percentage of hearing deficiency seen in children between the age of 0 to 14 years, and of all the deaf people in the country, 7% of people have a congenital hearing loss, which would have been diagnosed at the time of birth only. As per the report of All India Institute of Speech and Hearing, it is very clearly saying, just sorry, I turned the slide. It says, which was a survey done in 10 hospitals, including more than 12,000 newborns. They said 8.13% infants were referred on to OAE for further checkup. That is level 1, level 2 screening. Almost more than 8% children they required ABR. As per a study from CMC Ludhiana in 2013, the incidence of hearing loss in India is found to be 1 to 6 per thousand newborn. That is 0.4% of 1,000 live birth they were detected with hearing loss. If we go by another study from Maulana Medical College, New Delhi in 2015, it says that 5 to 6 children per thousand children born in India, they are deaf. The deafness is usually identified between the age of 1.5 to 3 years. So incidence of hearing loss at birth is estimated to be an average 1 to 3 per thousand, and hearing loss at school age is estimated to be over 6 per thousand. And parents and care providers need to understand the need for continuous monitoring. When we talk about newborn and infant hearing screening program, we talk about geographical subset, we talk about in a critical care area, we talk about high risk babies, and we talk about, which is the most important aspect, that's the universal hearing screening. It can be a family questionnaire based, it can be a behavioral, or it can be a physiological scientific assessment of the child. We all know that we have different milestones for growth of a child, which pediatrician usually follows between the age of 0 to 3 months, 3 to 6 months, 6 months to 9 months, and 9 to 18 months, 18 months to 2.5 years. The milestones are mainly based on the vision and hearing of the child. The pediatrician asks the parent, does he turn head towards when you call him by name? So when the child turns the head, it means the child is hearing normal. Or pediatrician asks the parents that does he turn the head on sudden loud noise, say banging of door and all. This is again a screening for hearing. But pediatrician only looks for milestones they do not specifically mention about the hearing status of the child coming to them. And then there is a behavioral screening between 3 to 6 years. So if we sum up the milestones, they are the cooing, babble, head turn, one word speaking, joint word, and making sentences. Now, if any of these milestones are delayed, so we have to tell our pediatrician colleagues that this is a child which may be having a hearing loss or hearing deficiency, should be referred to an ENT colleague for proper workup if has not undergone a screening. Now, in case of any of the milestones is not achieved, then you suspect hearing loss. If you suspect hearing loss, I'm playing another clip of the same movie Koshish. You just see that the father is trying to evaluate the child with a toy, but the child is not responding. So the father is very much concerned with himself, a damn dumb person, and the parents get concerned that the child born is like them. So he goes and consults a doctor, and see a doctor gets in and he just makes a click and the child turns the head. Now the doctor realizes that the toy the father was using was not having any noise making tool. It was empty, so it was not creating any noise. And once they put in, it shows that child responds to that toy. Now, why I'm showing this video, that when you are talking about neonatal screening, your tool has to be scientific, your tool has to be validated, your tool has to be feasible, because then only you can do universal screening program. If your tool is not validated, your program will fail. As an ENT surgeon, we know that we use autoacoustic emission as the first screening technique. Sounds are presented to the ear canal, and a small microphone measures the cochlear response in the ear canal, and we refer or pass. We say pass or refer. Pass means normal microphonics, and refer means that child needs further assessment or later assessment. So the second test we use for neonatal screening is the ABR, that is auditory brain response. We all know that auditory brain response evaluates the auditory pathway and is a very, very specific and sensitive test for the hearing assessment. But so technically it is difficult to perform in a child with all leads around. The child is always moving, so their chances of error and artifacts are very high. So these days we are using a barophone. I think that we all know what a barophone is. We use a barophone, which is a very, very simple device without any cords or leads, can be used by any trained person, and it gives you a graph as a barogram, and which you can interpret about the hearing, and we can be sure about hearing of the child. So what we do is we are using level 1 OE screening at the birth screen. Level 2 we are again following with the OE, the referred cases, and level 3 we are doing confirmation with ABR or barophone. So as per the guidelines of American Academy of Otolaryngology and NIH guidelines also, the first screening is done at birth. We do it with autoacoustic emission. If the child is pass, we consider as normal hearing. If the child is refer, we fix the child for a further screening at 4 weeks as a repeat OE assessment. We do OE assessment again, second screening at 4 weeks. If the child is passing it, we call it normal hearing. If the child does not pass, we refer, and then child undergoes a barophone assessment, and that is within 3 months, next 3 months. And if the child is having not a normal barophone, then we categorize the child as a special child which requires care and help. Now, what do families want to know when a child is diagnosed with hearing loss? It's a great setback and trauma to the parents when you suddenly tell them that your child is not able to hear, and is not able to hear, he may not be able to speak also. It's a big trauma to the parents. So what the immediate the question is, what do we do next? What action must be taken? When, where, how, who will help us? So these are the various queries the parents immediately ask, and why do we need early intervention? So we have to be ready with all these questions. The reaction of parents of a child which is born deaf and dumb is initially grief, then they go into the stage of pressure, then they get confused what to do with the child because various opinions they get. Somebody will tell them take a hearing aid, somebody will take okay start sign language, somebody will immediately advise a cochlear implant. So they get confused. So technical scientific evidence based opinion is required for the parents. And either if they many of the parents they simply go into isolation, that they are not able to accept the truth that their child will not be able to speak throughout their life. As per the nation and state goals for early hearing detection intervention, we follow the principle of 136. The screening should be done within 1 month of age. The diagnosis of hearing should be made within 3 months of age, and intervention should be done within 6 months of age. What hearing loss are we missing with newborn hearing? The best screening tests are not 100% accurate. But any accuracy more than 90% of a test is considered to be a good screening test. And OE and ABR both qualify for it. Now, if we talk about the status of newborn hearing screening program in India, this was a publication way back in 2011 from Pediatric Otolaryngology. And it was a questionnaire-based survey, 185 institutions, which were 165 medical colleges and 20 speech and hearing centers. The outcome was that almost 38% of the medical colleges and 80% of the speech and hearing centers they were following universal newborn hearing screening program. So it's a very positive study which encourages. We look at the other study published in Indian Pediatrics in 2014, which had more than almost 9,500 babies born in the hospital over a period of 11 months. And this study was totally based on Barafone. They did not use OAE and was published from CMC Vellore. And this used Barafone as straight screening instead of OAE. And they proved that almost 0.5% of the children newborn they identified as deaf. So it was a significant number in a study of 9,500. So if we talk about another study which was from AIMS New Delhi in 2015, published in Indian Journal of Pediatrics, where they did the standard two-step autoacoustic emission followed by ABR, and they used a Barafone, and the study indicated that out of total 496 children, out of total, I'll just exact number, that out of total 2,265 candidates taken for study, 2%, that is 2% children, they had hearing loss, which is a significant percentage. But at AIMS Delhi study, they said that there was significant loss of follow-up. That children who were referred on first OAE, they did not come for second OAE. So there was a big drop of patients, even in a tertiary center like AIMS Delhi. And another study which was published from Jipmer, Puducherry, in 2013 used high-risk neonates. They used OA and ABR, and they came to a conclusion that absent wave were in 5.5% of the neonates which were born at the center, and OE had a sensitivity about 92%. So routine newborn hearing screening, an Indian experience, was published from Mumbai in 2016 with 30,600 neonates, and they gave a that 58 babies, almost 0.05% children, they had hearing loss, congenital hearing loss, which is a significant amount. So the range in various studies varied from 0.5 to 5% in various studies in the premier institutes. Government of India has already launched a national program by the name of National Program for Prevention Control of Deafness, which was started in 2005 and 6 as a pilot phase. Today it is in 563 districts of the country. I have been associated from the very beginning as a pilot phase, and it is under NRHM, a very successful program which focus on manpower training, capacity building, service provision, on creation of database and IC activities, and focus is on early detection. Every CSC under the program has been provided with autoacoustic emission. Now, Indian Academy of Pediatrics in 2017, they tried to suggest that neonatal screening can be clubbed with the immunization program of pediatricians, and they also recommended that Indian Academy of Pediatrics, all members should follow neonatal screening as a routine practice along with immunization. But I did a survey about 5 years back. This was published in 2017. I did a study in 2018. I surveyed about 1,000 pediatricians that how many are doing a neonatal screening after publication of this article in the journal. And to my great disappointment, only 7.6% pediatricians agreed that yes, they do follow up neonatal screening with immunization. Rest were not doing, in spite of guidelines from Indian Academy of Pediatrics. Yes, most of the centers which are practicing neonatal screening, they are practicing a high risk pediatric population, that children who have a family history, have torch, craniofacial anomaly, low birth weight, hyperbilirubinemia, or toxic medication, meningitis, low Apgar score, mechanical ventilation, they which are in NICU or PICU, they undergo autoacoustic emission as a routine. But still, universal hearing screening program of all the neonates lacks in many of the centers. Uh, I try to understand why we are failing in promoting newborn hearing screening in India. There are various reasons. We are a very large population. We have a very high birth rate. 25 babies are born per 1,000 population. 75% of the population, they are in rural areas, and the most challenging thing is 50% of births, they are occurring at home, they are not institutional birth. And when we talk about data and statistics, we only talk about institutional screening, is institutional birth and data. The ratio of audiologists and audiometricians in population is a big concern. We have launched a national program, but still it needs more success. Institutional based screening is being practiced in many tertiary centers, but community based screening is still lacking in the country. Now, challenges in the cost is also a challenge. If we talk about cost, uh, it is excluding the cost of equipment. An average ABR test is costing about 300 rupees per test, including the manpower, the time, the energy that is costing. This was a study done by AIMS Delhi, published in 2015. So one of our colleague, Dr. Ramesh, who's working in St. John's, Bangalore, and I was very fortunate that when I was working at AIMS Delhi as a faculty, he was my senior resident. He, under a Make in India program, he has made an indigenous device by the name of Soham, which is very economical, few thousand, and it is almost like a ABR, and it is a good screening tool. We have done a validation of this tool at our institute, and it is freely available, and it's a very indigenous, helpful device. Now, when I'm making this presentation, we all medical scientists believe in evidence-based practice, but today, time is we have to follow the practice-based evidence. So we are lacking in our practice of screening, which will definitely create an evidence that what magnitude of hearing loss we are dealing with. Today, we all are here together to commemorate and celebrate or spread awareness about deafness on World Hearing Day. The theme is to hear for life, listen with care. I think we all have been busy since morning in various other activities, creating awareness. In my center, we had a screening camp, then we did awareness, we did competitions. So I believe in act as if what you do makes a difference. Yes, it does. Thanks for your interest in my topic. Thank you very much. Uh, uh, Dr. Murthy,
Yeah.
sir, yeah, I think I could fulfill your expectation uh, as per
Oh,
my
yeah, yeah.
efforts. Thank you.
You have
Thank
done
you.
an excellent job. Great job you have done, Saurabh. So
Thank you,
just
sir.
two, three comments I would like to. Your Koshish movie reminded me of an incident.
Sir,
I mean, most of you probably know Hazarika.
sir.
Dr. Pradil Hazarika was my boss at Manipal.
Okay, sir. Okay, sir. Okay, great, sir. Great.
So, and Dr. Hazarika has got sensory neural deafness,
Right, sir.
and he was blessed with a son.
Right,
So we all
sir.
went to see him along with him. This
Right,
guy
sir.
didn't even bother to see his face. He just went and did a clicking. He just wanted to know the son has got a normal hearing. That's all he wanted to know. I mean,
Correct, sir.
that's how important is hearing. When I mean that will be only known only for the people who face it. I'm also an active member of the National Initiative for the Safe Sound. Well, and I'm
Right,
in
sir.
charge
Right,
of
sir.
the
Right, sir. Right, sir.
I'm supposed in charge of Andhra Pradesh. But
Right, sir.
unfortunate thing I would like to point out is because you are also very actively involved in the national program for the fitness in Andhra
Yes, sir.
Pradesh. Somehow the program has not taken off.
Okay, sir.
I mean, I've been trying to get it from the because when the state has been divided, there is money has to be divided between the two states. There are some problem. I mean, I've been trying to talk to the DME also, but meanwhile the DMEs keep changing. So actually, I'm from the association side. Probably we have to do something about this one. I
Definitely,
mean,
sir. Definitely, sir. Definitely, you
and
should,
we
sir.
probably will require you will need your help also in that.
Sir, 100%, 100%. Whatever I can do, I'll be always there, sir. Always.
In we have started this program in Oman in 1998.
Right, sir.
1998, we started the universal neonatal screening program in every hospital because most of the deliveries in Oman are hospital delivery. So
Correct, sir.
we made it mandatory that every child has to be tested by OIE by next day morning, 24 hours.
Right, sir.
And the program was very well went off, and Dr. Marginal Kapoor is also one of the very important members of the WHO deafness programs. These are a
Right,
few
sir.
comments I would like to make. Thank you very much, Saurabh, for the beautiful topic.
Thank you, sir. Sir, sir.
And I want to
Any
know
other
where I can get
any
Soham.
other sir participant wants to make their comment because
No,
I know there are many senior, many experienced people in Andhra. So I know many of them, but anyone wants to share their experience, they're most welcome. That would make me to know more something today. Yeah,
where can we get the Soham?
Yes,
sir. Soham is available online, sir. And if you want, I can share you the contact of Ramesh, the person who has invented it, and it has been patented by DST. It has been patented by DST.
That
So
will be
yes, sir.
that will be very much
Sure, sure.
appreciated.
I'll share the email and contact number of Dr. Ramesh. He's a faculty, he's a professor of ENT at St. John's Medical College, Bangalore. Yeah.
Sure, okay, sure. Thank you.
I'm Dr. Paul, sir.
Sir,
Hello.
sir, very good evening, sir.
Good evening, everyone. The presentation of Dr. Saurabh is excellent, and the way you guided us is very useful. And in Andhra Pradesh, the government is very much interested to take up this project, and the NHMs are also it is helping us. And recently, we trained many of our PHC doctors throughout the state regarding the child screening from the newborn to screening process and implementation of various treatment protocols. Yeah, this project is going to be started by Andhra Pradesh government very shortly.
Very nice.
And
Very nice.
we with the help of our senior professors like P.S.N. Murthy and our association, Dr. Rahman, Madhusudan, and everyone, we are going to start it very soon through the government. This is
Very good.
my input, sir.
Very, very, very nice, sir. Sir, I'm sorry, I forgot to thank Dr. Ataur Rahman, sir, because he has been in contact with me since yesterday. My special thanks to him, because he was coordinating on behalf of AOIAP, and he was so cordial and very, very, very. Thank you very much, sir, for all the help and assistance, sir. Thank you. Sir, I think if there are no more comments.
Sir, good evening, sir.
Dr. Bhargav, how are you? Nice to see you.
Sir, I'm good, sir. I'm good,
How
sir.
are
How are
you?
you? I'm good, sir. How are you, sir?
Sir, all fine. Sir, Dr. Bhargav worked for some time with me as a senior resident. Nice to see him.
Yes, sir. Yes.
Yes, good.
It has been a privilege working with you, and I feel lucky to be as a part of as an attendee in this discussion, sir. As
Great.
always, it has been insightful and thought-provoking, sir.
Thank you, Bhargav. Thank you.
Sir.
Rahman sir, you are not audible, sir. You have to switch on your mic.
So you need to unmute yourself. Yes. Not yet.
Hello, sir. Our president, Dr. Srinath Garu, will speak, sir, for a few words.
Sure, sir.
Srinath Garu. Sir, I will speak a few CV of our speaker, Dr. Saurabh, sir. He is, sir, am I audible, sir?
Yes, sir, you are.
Yeah.
You are audible.
Is the Dr. Saurabh, sir, is the Executive Director and CEO of AMS Diogar, Jharkhand, and is on deputation from Professor and Head of the Department ENT and Head and Neck Surgery, All India Institute of Medical Sciences, Rishikesh, Dehradun. And he did MBBS in 1990 from Jain Medical College, AIMU Aligarh, and also MS ENT in 1994. And he has a diploma in hospital administration and postgraduate diploma in medical legal systems and certificate courses. He has global tobacco control, second-hand smoke, antimicrobial stewardship and competency-based approach, WHO, and certified console robotic surgeon. He is a fellow of so many organizations. He is the National Academy of Medical Sciences, American College of Surgeons, International College of Surgeons, International Hearing Federation, International Medical Science Academy, Indian Academy of Otolaryngologists, Indian Academy of Biological Scientists, and Academy of General Education. And he is given 10 radio talks and 2 Doordarshan talks and 56 guest lectures and 12 orations, international 1 and national 3 and zonal 2 and state 6. And he is organizing chairperson, secretary for 5 workshops and 3 symposia and 2 conferences. He is an expert in Public Service Commission, Uttarakhand, Jammu Kashmir, UPSC. And is examiner MBBS and MS DNB various Indian universities. He is a member editorial board 17 journals and reviewer of 21 journals, reviewed 300 articles. And his other positions are secretary in North Zone AOI and president of Uttarakhand branch and president IMA and other.
Hello.
He had 21 awards to his credit: AOA Travel Fellowship, Vikas Ratne, Guest Teacher Award, National Academy of Medical Sciences, International Guest Scholarship, Yusuf Patel Fellowship, and other. And he has 268 publications, national and international journals, and 107 papers presented national and state level conferences. And he has attended 100 conferences and courses. And he has 9 chapters in the book and 2 books compiled, and co-author of 2 and GOI manuals, National Program for Prevention and Control of Deafness. And his special interest is deafness, medical education, tobacco control, endoscopic sinus surgery, and head and neck cancer surgery. Thank you, sir. Thank you.
Thank you very much, sir, for your kind words. Thank you.
Now,
Hello.
Dr. Bapa will give a vote of thanks, sir. Dr. Bapa Rao.
Yes, sir. Good evening, everyone. Sir, after listening to your lecture, we got a lot of knowledge regarding the hearing screening program which is going on, and there are some lacuna, as you said, which needs to be filled up. We are definitely looking into all those things. We're definitely optimistic that we all will implement this neonatal hearing screening program in a better way. Thank you very much for your wonderful lecture and your time, sir. And I thank
Thank you.
Professor Dr. P.S.N. Murthy Garu, who has always been the driving force of our ENT association. So he made it possible on this day, World Hearing Day. Thank you very much, Murthy sir. And special thanks to our President Srinath Garu and our Secretary Rahman Garu for making this event possible. Thank you one and all.
Thank you, sir. Thank you very much, sir.
Thank you, sir. Thank you, and my warm regards to all of you for
Thank
just
you.
giving me an
Thank you.
opportunity. Thank you.
Thank you. Thank you
Thank you,
very
sir.
much, sir.
Thank you, sir. Good night, sir.
Okay, sir.